back feed. Thank you. All right, so folks, I've just started the recording and transcription for today's meeting. Everybody needs to be able to consent to this. So if you do not wish to consent, will you come on mic and share? And then we'll stop recording if that is the case, but otherwise we'll go ahead and move forward. Good morning, folks, again. And I was just beginning to share that we're in December and we are really fast and furious, focusing on the changes that need to get implemented for January 1st regarding the demonstration for the SUD IMD demonstration and incorporating what is needed for the reentry benefits that we're opening up for 1/1/25 and the CCBHC work, and then related also to the across the CMH system because of services that need to be added for both of those models. I know that right now there are a ton of people waiting for the coding lists to be finalized. We've had a couple more things surfaced. Recently, we received an update on HCPCS codes that added some new codes for individuals who have Medicare. Some of those codes do intersect with the work that needs to be done for those 1/1/25. So I just, like for instance, I just came out of a meeting regarding SUD codes, G codes for Medicare recipients that we have to suddenly hurry up and figure out, are these things that we need to go ahead and turn on in the system? Are they in our state plan? Are they not in our state plan? Things like that. I believe there are some specifically regarding the CCBHC coordinated care type services. And we're getting into a space right now in these conversations where we may have to differentiate the G codes that need to be added to the system in terms of, are these getting added for individuals that have QIMBY Medicaid benefits, and to make sure that if we populate those, that we are incorporating in our guidance documents and in a fee schedule in a way that folks understand that they may be open because they're covered under Medicare and then under Medicaid for the coverage of the copayments and deductibles, even if they're not a covered service under our state plan. So that's part of what we have to sift through. And that's brand new. This is stuff that just emerged this past, late last week, Thanksgiving week. So we've had basically about a week to go through those. Kelly, go ahead.
So just because you lost me at the beginning, so I just want to make sure I understand, because you started by saying that people are waiting for the coding list to be shared, and I had no idea what you were talking about. But the rest of it, you're referring to the national coding updates, the CPT
Yes.
updates? Okay,
Yes.
thank you.
Yep, we just got some new ones and they happen to, of course, hit the behavioral health space. And while we're working on the 1/1/25 things, we have to identify if there are intersections with the 1/1/25 activities. So more to come on that.
Diana, before you go too much further, can I just ask, the last time I was able to attend, we had asked for a copy of the transcription, or I had asked.
Yes,
and
yep.
I didn't receive a transcription copy, so I'm just making sure you're still doing that, and also want to ask you so that I can have this and process with my team later, and ask you to forward them if you do have them.
Yeah, let me see if Lorian is on. I tried to do
here.
those last week. Lorian, so I know it was just yesterday or 2 days ago, I pulled the transcripts down and the video down. Have we sent that out yet?
No, the video just got posted late yesterday, so I haven't gotten the email out yet, but I will do that.
Okay, great, thank you.
And I guess I'm sending it to everyone on this invite. Is that the plan?
Yes,
Okay.
yep, I just grabbed the
today.
invitation and I do send the email to all. Thank you. Thanks, Suzanne. And that will be for the last one. So this should be a second set of the transcripts that you'll get. The first one already had gone out since you made that request. All right, so when we last were here, we were talking about the directed payments, and I shared that CMS had approved our SFY calendar year. It's an odd one because we're in the middle of this MCO contract, and usually it's a 12-month cycle, and this one is going to be a 10-month cycle, I believe. So we got that approval, and we were going through to finish out our understanding of where the time clock would start for the new timely access, where an individual needs to receive an intake within 30 days to from the date of application to qualify for that directed payment. And they did approve it at that amount that we had talked about, the $2,000 something amount. And I believe what we had been working towards was a unified approach of how that would be reported to the department. And we talked a little bit about that. I don't know if Patrick's on here. If Patrick, he is on here. And I sent an email
Yes, he
because I
is.
had been looking for it and I didn't see the email come through yet. I believe after our last session, there was going to be a little bit of a regrouping between the centers on that topic. So Patrick, I don't know if you can update folks or if there's someone else from the CIO group who could, but that would be helpful.
Yeah, I can update to the fact that the communication went as planned to the CEO group. I really can't provide any insight as to what happened.
Okay.
In their group.
Have we landed, CEOs in the room, have we landed at a position for that? Because I need to get the document, the guidance document done. So this is the only really new thing that we're adding. So understanding how the department will receive the information. I believe that the part of the plan was that the centers weren't going to submit the starts of all the clocks only for those cases where we believe the intake did happen within that 30 days. So essentially a successful timely access to service that would be submitted. And I don't know if that's coming through Phoenix, if folks are going to send a monthly report, but I do need to make sure I leave that with Andrew Chalsma's team for the tracking of those directed payments. Also, not just for you guys, we need to internalize it also.
So I'm just going to try to speak because this will be difficult for me. I'm pretty sure we all agreed on the definitions. We all have our own way of collecting the data already. So when you come in for an intake here, if you came in through open access, your intake date and your start date are one and the same, right? For those who are outside that, which there are a few now, but if you had a call that came in and then you had your intake, you would need both sets of data, right? So you'd get one set of data that the intake was complete and would give you the date that would be the exact same date as the intake date because it was an open access patient. And then those other ones, you would get two dates. You would get the date the intake was completed and the time that the initial call was taken by the patient, not the guardian, not New Hampshire Hospital, what have you. There's few and far between of those nowadays, but if we have that, we'll give it to you. We don't usually tell you how we want to give it to you. You usually tell us how you want us to give it to you. So I'm a little confused because we give you intakes on Phoenix now, right? You get all of our intakes on Phoenix. You just want that extra date that might exist for some centers for the way that they're doing it. And I think you have to tell us how you want it.
So thank you, Maggie. Normally, yes, that's how we would approach it. But when through these sessions, what we've learned is, as you just shared, many of you have different ways of doing it. But I know it's been a goal of the CIO group to try to unify the data reporting as much as possible. I think that's what I had heard out
Yeah.
of these conversations. So we wanted to be open to what you were working towards to see if we can accommodate that as well.
Yeah.
Certainly, we don't want more administrative burden. We'd like less administrative burden.
And to clarify, Diana, it's not really the CIO group. It's really a group that includes QI people, data people, the state, and we're all collectively trying to make sure that when we report out, the information is consistent so that basically the reports that ultimately get generated are consistent. And that's that group. But some of the things that are being requested, I think, as Maggie's pointed out, ultimately it is the state that says to us, okay, now report it this way. And then we comply. And we really appreciate the opportunity to provide the feedback and work with you all in coming down to a common definition. I believe at this point, Andrew, through some other people, has the information that also has been provided to the CEO group. And he's familiar too with the things that Maggie mentioned, I believe, about the specific differences among some centers. So if, I don't think this meeting's probably the place to wrap it up. If there's something that I can do to assist with that, I'm certainly interested.
Kelly?
Yeah, I was just going to follow up. I really wanted to follow up before you told us how to do it. And say she's giving us the opportunity to come back and say to her, this is how we all think we can give it to her. Not this, we understand all the definitions. We've sort of filtered that out. And so I would propose, Patrick, if you want to come back and convene your group and get consensus on, as she said, is it coming in Excel? What's going to come in Excel? If she just needs a solution here and she needs it in short order.
Because we originally talked about how I figured it would be is generally setting up a new Phoenix code that you'd receive, something that would document that you received the application, the knock on the door, the phone call, that meets the definitions that we've landed at, right? And I thought the initial sense from you folks was that you didn't want to have to put into Phoenix every time you got a call from someone saying they wanted to start services, because that would, in the CCBHC space.
Yeah, we had agreed, again, there's been a briefing provided. We'd agreed on all the things you're speaking about, I believe. Right. I just don't want to put out there that I'm the definitive, but all those things have been agreed to. The thing that was still, I think, being worked on was the clock, right? And the question of reset, reset of the clock, the reset, not the start.
Right, the reset.
I believe it was the reset of the clock. And so let me just get confirmation from people that I have, the ability to respond in the way I think I should and get back to you.
And Heather, was that what you were going to talk about?
Yeah, exactly. And really, we're already providing the first contact date in our file. So we don't need an additional code or anything like that.
In what file? Are
in our Phoenix files. Yep.
Okay. So all 10 centers document first contact. Yes.
All 10 centers have replied that if they are not documenting first contact, they believe they're technically capable. And again, I think a definitive will come to you that is correct or not correct post meeting.
Okay, so when you're talking about the reset of the clock, that is if you have your first contact, you've got an intake scheduled for somebody, they no-show, then you have to reset the clock internally.
Yeah.
For another 30 days, because you're not going to get penalized if they no-show.
Well, it's when does that reset happen? Is it 30 days? Is it 90 days? Is it 120 days, 180 days? And I think that we had closure on that too, but I'm not really positive. So I don't want to put something out there that's not accurate to the group.
Okay. Because you all are right. We already know when you're doing the intake, because the using the intake as a trigger for one of the directed payments that we already have. That's like the timely prescriber. So we use the start of the clock for the timely prescriber as being the intake. Excuse me. All right, I'll be right back.
While we're waiting, I have a quick question. I thought that I had heard that some of you were talking about that you exclude data from the pre-admit, but the pre-admit would be the area where we have the phone call where that person would be reaching out for the first contact. So I was just curious about that. Had that been part of the data?
It was. Yeah, there's been a lot of discussion around this concept of pre-admit and then admitted people, right? And the reality is, since we're reporting it in the Phoenix file, there's a number of data elements that are required and have to be reported. And at various phases of the pre-admit, you wouldn't necessarily have those various data elements. And so in the interest of making sure that we were reporting full and complete data, there is a point at which somebody becomes a person that is going to have the data captured, and that's where they're being reported. Is that helpful?
Yeah.
Right. And then maybe further, just to, if you have that, then that's what date you would put in your file once the client's open. We're just not sending pre-admit people until they're open, right?
Got it. Okay.
Right.
So once they're actually admitted, then you can pull the data from the pre-admit when they made the phone call. That's basically what you're saying. Okay.
Correct. Yep.
And what if the individual gets their intake and it's determined that they don't meet eligibility, CMH eligibility?
Anybody that gets an intake, I believe, across the spectrum, but again, correct me if I'm wrong, people, but if they get the intake, they're then a patient, right?
Well, if they're CCBHC, they'll be a patient because they'll fall under AMI. But currently, if someone we do the assessment and the intake at the same time. So I guess that's the difference, right?
Yeah, if in a standard, I mean, in like a standard CMHC, you've done the intake, the person has all the information before they come into the intake, so they're actually a patient, right?
But
so it's consistent across models. Sorry.
And we're also sending that eligibility status in our files as well. So you would be able to see that they're not eligible.
Right.
Right. That's why I wanted to make sure. I was a little bit concerned that what I was hearing was that we would be, that there really wasn't eligibility being determined during the intake, because the directed payment is tied to that eligibility status.
Yeah, as Heather mentioned, the eligibility status is provided in the file. That's one of those pieces of data.
No, I'm not. I just meant in practical. I know we get the modifiers that tell us if they're eligible. I just wanted to make sure that if they ended up being AMI instead,
you get it in two
folks
places.
Understood that.
You get it in the claim data that's coming in, as you pointed out. Submitted also in the Phoenix files.
Right.
But Diana, are you saying basically that the incentive is only for people who become and are eligible?
The language ties to here's the awkward part, right? So the language ties to they get the intake, and I'll have to go back and look at the actual document, but the overarching element of the community mental health directed payments are that it's for the SMI plus population. Now, I may have said before that it doesn't matter if they have it or not. So let me double check that, Phil. I think what was happening just now is that I was hearing patient, 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 and my brain was kind of thinking about that, like, well, wait a minute, they need to be like SMI. So let me not make a mistake in saying that. So let me
Okay.
back it out and I'll confirm.
That'd be
Jay?
great. Yep.
When you
Thank you.
say SMI, are you meaning this would be adults only, or are you just
Nope.
saying that
That's why
generally?
I
And
said plus. Yeah.
Okay.
It's just easier. I've just started doing that in like the past 2 weeks because there's, lots of the acronyms to cover the subpopulations.
Thank you.
So back to the start of the clock. Am I hearing that the data is going to come through Phoenix that includes the start of the clock for timely access?
There is data in the Phoenix file that includes things that you could determine basically the time between events. So the answer would be it could be calculated from there.
Okay, so those codes, Andrew already knows which of those codes that will be used. There's been like sort of separate conversation because I was going to go back to Andrew's team with the product, the result of this conversation.
I believe if you asked Andrew that question, he would say yes.
Okay. And earlier, Patrick, we had said that all 10 centers can, they either are already reporting that first contact or they can. So are all 10 centers on board with that you will report the first contact via Phoenix? I'm
I
seeing.
believe the answer to that is yes.
Okay, so that was the part we wanted to make sure of, right? Because I think it was Patricia last time who hadn't really known if they were going to do that. Manchester, are we good with that then? Whoever's here for Manchester?
Absolutely.
Okay, Heather, thank you. All right, so that is really, really helpful. I'll loop back. All 10 centers. All right, so all 10 centers will document first contact by Phoenix. Okay, and then you folks will internally manage the clock reset, right? Is that what I heard? Also, Allie, I see your hand raised.
I just wanted to clarify, this is for the timely access to service directed payment.
Yes.
So I'm
Yes.
just reading the slide that you guys had shared a while back, and it does say applies for children and adults meeting CMH eligibility.
Oh, thank you. You pulled that up faster. Good. All right. And I think that, thank you for pulling that up. So Phil, when we think back until what those conversations were, most of the centers are doing some sort of pre-screening already before they're scheduling the actual intake, right? Is that why, like, nearly all of the time the actual intake does confirm the full eligibility results in the ISP, et cetera? Okay.
Yeah.
That
we're
makes
setting,
sense.
Yeah.
Okay. All right. So when we do the guidance, just so you know that how you reset the clock, are you going to sort of operationalize that the Phoenix data will set up a new reset of the clock? And so when we go in, when Andrew's team goes in and they'll look for the intake and then they'll do the look back of 30 days, they would see, will it be the same code and you're just going to reset the date? Or would it be a different Phoenix code that they need to identify?
Yeah, I think that the great thing about using the data set as it stands is you have dates that the data come in with the service data and everything else. And so they're able to actually, even if you were to change the parameters of when you reset the clock, they have the data already. So they'd be able to evaluate it.
Okay. All right, great. Okay, that was the big, huge one. Now, this goes back to September 1st, technically. As we all know, CMS often sends their approval many months later. And I guess this was pretty good for us because it's typically about 14 months, apparently. So have you folks already been tracking this somehow, and you're going to send us some Excel reports, or would we be able to go back already to 9/1/24 and see the first contacts in Phoenix?
At least for Manchester, it wouldn't match the current definition that we've all agreed upon. So no.
Yeah, and it's not just, I think, Manchester. There's actually, we've recently agreed upon a number of these operational definitions. So the data across the centers would be varied, right?
Mm-hmm. Okay, so the operational definitions that are agreed upon, you must have those in writing also. I know we've talked through them and we've taken notes in the PowerPoint that I usually share, and I'm like writing comments right in. Do you folks have something where that operational definition is already in writing that you could either throw in the chat or send me by email?
Yeah, I'm going to defer to, I mean, there are 3 participants in the group from DHHS, and I think that information is present. I mean, through that. So I would check with Andrew and his team.
Okay. All right. And who are the 3 individuals, Patrick? Andrew, Sandy, Connolly, probably?
Yeah, I'll get that back to you. I don't want to misstate.
Or what's the name of the work group? And you don't have to worry about the names. I just want to make sure
It's
I'm using the
I'll
same
forward
words.
I'll forward you the participant list. Okay.
Okay.
Yeah.
Thank you. All right. So what do folks want to do? What should we plan for in terms of getting the information for, let's just call it the successful, the transactions that would qualify for the directed payment back to November 1st? I mean, September 1st.
Okay, I'm not sure what the question is, Diana. Is it how soon do you have the money that you want to give me, and how am I going to give you information so you can give me my money?
So the money is already in our budget, so it's already there. It's already in managed care. And we have CMS approval. So we have CMS approval back to September 1st. So how do the CMHCs, and if you don't all want to do it at the same way, that's fine. I just need to, my last day with the state is 12/26. So I have to kind of wrap up and do the transition planning and tell people, oh, you should be receiving this by such and such a time. If it's going to come a certain way, we just need to make sure to plan to make sure that we get the information in on how we want to handle the retro part. Once Andrew's team sets up the sort of data analytics for going forward, that's fine. But for the retroactive, I can go back to Andrew and they can just, look at those Phoenix codes, but I don't think it's all going to be there yet. I think that's what I'm hearing. So are the centers wanting to submit like separate reports on Excel for those qualifying cases, and we can use that as like a backstop to what we're seeing when we analyze the Phoenix codes?
I'm not sure how to answer that without my IT team sort of on this and my report writer, but and also just thinking about our EMR transition and how we're going to collect all that to make it clean. So I feel like I'd have to get back to you on how we could handle the retro, and you're going to potentially get 10 different submissions.
Right, that's fine.
And then, Diana, to facilitate the answering some of these questions. I'll reach out to Andrew and I'll make sure that he has all the information that you're requesting from.
Well, that's
the
what I'm
group.
gonna
Yep.
loop back with him, but you can too. So why don't we just leave it
Okay.
at this, that the centers will identify and share their approach to the retroactive timely access to services qualifying events. And if you send it to, we'll have you send it to Andrew. Hang on a second, to Andrew Chalsma. I think Jennifer Polini is going to be the one working on the directed payments. I'm going to add Lorian Wilson from the policy team here that we have, because the policy unit does a separate analysis about all of the directed payment experience. That's outside of Andrew's team. So you'll send it to Andrew, Jen Polini, Lorian Wilson.
The other participant
and
is
Kelly
Maria.
Liberty.
Maria also participates in that group.
Maria.
Costs of.
I don't know that person.
I don't have it. Okay.
That's okay. That's interesting that I don't know that person.
So
Okay,
for the
Andrew Schosma.
retro, where we are not going to use Phoenix, I'm assuming this has PHI information, and so can we get instructions on how? Maybe maybe my staff, I don't know that they are actually out here today. Who could answer that? I want to make sure that we have a plan for how we get it securely.
Okay. Do you folks use the SFTP process right now for getting the data to Andrew?
Yes,
okay.
Seacoast does use it.
I'm guessing that'll be the same way. Thanks for pointing it out. I'm just putting notes in the chat, Jay, so I don't lose these thoughts here. Lorian, Kelly Liberty. Okay. And then Carolyn Lewis, I don't know if you're on right now, but I'm going to put you in here too as well.
I'm here.
Hi, Lori. What would you like to say?
So do we have the dates for the retro? Are we going September 1 through December 31st, or is there a cutoff date? Do we know those dates yet?
Yes, let's do that one right now. We do want these to go September 1st through December 31st, I believe is what we talked about, because then we'll line up with the last 2 quarters lining up. So yes, I will put that in the notes. Thank you. Retro period 9/24 through 12/31/24. There we go. Okay. All right. So I put those notes in operational definitions. We've got the retro covered. Does that sound about good for right now to wrap up that new one? Okay. Thank you. I heard someone else speak, but I don't know if they're speaking to the audience or if that was unintended. Okay. Thank you folks so much. So one of the other things we'll be providing is, and Maggie, I know this is something that on behalf of the CCOs you guys have been waiting for, that updated DBH Medicaid initiatives list for the things that will go forward after we get past the new year. The IROS guidance has been drafted. I just need to, and just for everyone's sakes, that IROS guidance is addressing that the prior authorization to exceed the 10 units is no longer needed. Bundling is still going to be allowed. However, the one thing with lifting the prior authorization we need to be cognizant of is that the clinical record will need to really well articulate what the person needs for those services, the IROS services that normally could be all bundled all the time, right? So that if we're audited by the feds, or we're having MCOs do audits or whatever, that the volume of services people are getting aligns with what the clinical plan is indicating they need. So we just need to make sure that folks are looking at their clinical documentation well. If everybody is billing a lot of services past 10 units and they're bundling it and we don't have visibility into how many were service A, how many were service B, right? Then it's hard to reconcile that back with a clinical record. We I have some language that we're using for the opioid treatment programs because they have a number of billing options that are about bundling of services. And the department did have a very negative OIG finding a few years back because we didn't have an effective way to trace back to the medical necessity and what the clinical plan called for. So we've done a lot of work in that space to help do that. So the guidance will include some reminders essentially about making sure that the clinical documentation that's called for in the ISP is mirroring sort of the utilization experience that individuals are getting. So I pause there because I feel like that's nothing big, what I just said, but I don't know if it is to you folks. Makes sense then.
The silence means that it makes perfect sense to us, and that's how we've done business for a long time. So don't sweat the small stuff, as they say.
Good, great, thank you. So that is, today's Friday. I'd hoped to get it out today. I don't know that I have access to who I need to for that today, but it's like 99% there. The plans for the adult community entry, I'm going to ask the demonstration team to come back to one of these meetings, or we'll schedule a special one. So you folks may recall we had Carolyn Richards come in and talk about the adult community reentry. That is the one where I think my last update to you folks included that the pre-release service would be essentially like up to half an hour, kind of get to know you pre-screening type thing. And we identified, the department used its coding consultant to come up with a code for that service. I shared what the code was. So none of those things have changed on that front. The goal is still to try to have that free screening code used for the CM, if it's an individual that would be receiving services at a CMHC or a CCBHC, to have that happen under the demonstration pre-release. So it won't get added. There's no state plan change we have to make for that. The service is just under that demonstration. We won't be opening up that code into the regular Medicaid space, into the regular fee schedule, because you folks already have your intake process already in there. There's no sense in sort of building a new thing in there. So that hasn't changed. The peer support service has not changed either from when I last updated you. The biggest thing that has changed, and I think I shared this with you folks a little bit the last time, is that CMS is now requiring the states to do what we call a youth reentry benefit. And that is, it has some different ages depending on if the youth meets the definition of just the youth and the regular age up to like 21. If there were pre-existing conditions, for example, versus up to 26 if they are former foster care. Suzanne, it looks like you're going to have a question on that.
No,
okay.
I'm just confused, and my face always gives me away. So I'm just waiting to hear.
Yeah, and so the youth community reentry work, the department set up a separate work group on that, and they were really looking at it more from the physical needs of an individual rather than about behavioral health. So the physical health part of Medicaid took on that work, and I've only been pulled in a little bit here and there. So I don't have a great handle on it, but of course, we know that we have youth that will be reentering the community that have behavioral health needs. So that's why I would like to bring that team that can give you folks the update on the adult community reentry and the youth one to you. That group has been having weekly or bi-weekly sessions with the managed care organizations. So they are getting brief, but I know you folks haven't received a brief on that one yet. So I want to make sure that happens before the end of the month. We aren't anticipating a high volume from that population anyways. The other thing is there are aspects of a youth reentering if they are a youth under the juvenile system, and they would have a juvenile probation and parole officer versus the adults, right? The adults they may be able to select what part of their state they're going to re-enter into. They can, request the services or deny the services we're opening up under the adult benefit. The youth will have a different kind of management around the case. So there are nuances there, and I think they're still sorting out some of those nuances. So that's what I have for an update on the reentry work. The SUD services, so to add targeted case management to SUD, there's no change there. The code is out there. The rates are out there. We'll provide the guidance about what that targeted case management will look like. It'll look like much of the others, except it's going to be a per diem. It's not going to be the monthly that we're used to for the SMI plus population. Anything else that I might have missed for what's percolating like immediately for January, Allie?
Did you say that the peer support code that is being added to the CMHC fee schedule?
Yes.
And the managed care companies are aware of that and will be adding that code on their side as well?
Yes, they know that is in there. We've based on feedback from you folks, we're anticipating it's largely fiscally insignificant for the peers, because I suspect many of you, the vast majority of what your peers are doing will still be billed under IROS codes rather than the new peer code. At least that's the feedback I think we heard here. But the code will be set up, and for those centers that are choosing it clearly just for the peer rather than the IROS services, you'll have both options.
And there's no daily limit on that, correct?
There will not be, no.
Thank you.
And the crisis billing guidance, to wrap up on the and in addressing it in 3 separate ways for crisis stabilization center, and ARPA compliant mobile crisis, so it lines up with the state plan. That is that you should get before the end of December also. So I have like very significant targets of things that I need to wrap up by December 26th. So they're in a good place for folks. And we all know that things are subject to revision. Sometimes the department doesn't quite land the language exactly right, and you folks with your institutional knowledge set us straight. And so we'll get things out, and if we need more revisions, you'll have your contacts of who to reach out to start those conversations also. Chris?
Yeah, sorry, I have been out a bit, so I may have missed it, but I don't have the code for the re-entry, and I'm just wondering, it sounds like people have it, so could you either send it to me or maybe direct me to where it was sent so I could track it down?
Yes.
Thank you.
Thank you. One thing I wanted to ask is, I know the CCBHCs will need to, we'll be serving the SUD primary population also. And some of the centers, how many other centers are serving SUD primary? Chris, is your hand raised to answer, or is it just you haven't lowered it yet?
Oh, sorry, I'm a beginner. I don't know how to lower my hand, but
Oh,
we do
okay.
serve SUD.
Okay.
When you say primary, do you mean SUD only?
Yes.
Like we have a program that does SUD only? Yes, we do.
Manchester does. We do co-occurring.
I'm sorry, who does what?
Manchester has primary SUD.
Right, but you'll be a CCBHC.
Yeah.
Right, yeah, okay.
We do treat some primary SUD only.
You do,
Well,
okay.
This is certainly not our main population, but we do have some.
And Chris Mumford, you're which CMHC again? I'm sorry.
Riverbend.
Riverbend. Okay, so Northern said yes. West Central, Lori, do you folks do that now? No, Lori, okay, both Loris, thank you. All right, Riverbend, Monadnock?
Yeah,
Bill?
we do. Yeah, we do.
Okay. 5, 6, Nashua. Nashua is becoming a CCBHC. Manchester is. Jay, how about Seacoast? You're muted.
We have some. We don't have a discrete program any longer, but we do have some patients who are SUD.
Okay. That brings us to community partners.
We do not currently do any substance use only. However, when we close with Southeastern, we will have an entire unit that does that.
What's your ETA for that, Chris?
Our target is the end of the fiscal year. So we'll be starting up.
You have a calendar year, fiscal year, or a different cycle?
Okay. Standard state fiscal year, 7/1. So we look to close
state
6:30.
Year, okay.
Yep.
All right.
Looking to close 6:30 and start those operations 7/1.
Okay, thank you. And then CLM?
We don't have a discrete program. We treat co-occurring.
Okay, all right. So the reason why I asked that is it has been surfaced within the department where we're seeing sort of growth in this SUD space within the CMH system. That there's a couple of things that we need to figure out, if you will. SUD providers have a different provider type than what the CMHC does. I think at least one of you has enrolled also as an SUD provider, but that question becomes, do we need the CMHCs that do serve SUD primary to register as an SUD provider type? So there are pros and cons to that, and besides administrative burden, right? Under the administrative rules for the SUD services, a community mental health center can be an SUD provider. And the department didn't in previous times require separate enrollment for that. They just, what they did is they put your provider type as an allowable provider of those services. So they took those billing codes, allowed the 093 provider type to bill those services. There are some concerns about continuing that because SUD providers have a different audit tool that the MCOs use. We looked at the potential of incorporating additional elements of the SUD audit tool into the Community Mental Health Center audit tool. And our partners in the Bureau of Drug and Alcohol Services have some concerns about that. We're really trying to mix an apple and an orange in that audit tool by doing that, and they'd prefer to use the separate audit tool. And that ties into that OIG audit I spoke about earlier that happened a couple of years ago in the SUD space. It wasn't limited just to the opioid treatment programs. So there's a provider type question there. The other thing that impacts that provider type difference is under the SUD provider type, all of their rendering providers have to be on the claims. So you have to enroll all of your rendering providers. Under the community mental health centers, we have not required compliance with that. The department has essentially waived that requirement, even if you're providing the SUD services, and that was to reduce administrative burden. The reason I'm sharing these things with you is because there won't be a decision on it by the end of the year, so I won't be able to carry it forward into the future. But someone will obviously be having to have these conversations with the CMHCs once the department starts sorting through this a little bit more. I see Jay and Allie that you have your hand raised, but I want to make sure I'm leaving you with what I know first, because I want to make sure it gets said to you. To me, the most significant concern and support there is for having that dual enrollment as an SUD provider is if there are any negative audit findings that come out, you have insulated your organization's book of business for the SUD population from your CMH population, which means an adverse audit, I can't say that, those two words together, an adverse audit outcome on the SUD side, if you did not have that separate enrollment, could have billing claiming shut down for your whole organization. So by having that separate provider type, the department would have the ability to put the pause on just the SUD versus the CMH. That's nowhere in writing right now for us, right? We're just having these conversations right now, but the folks that were at the center of resolving our work with OIG are the ones who said, look, this protects them. So as you're considering these things moving forward, if you want to expand your services to the SUD population, it would be constructive to think about these implications. All right, so Allie and Jay had their hand up.
I was just going to say that, for Manchester, it may not matter for us moving into being a CCBHC, but for others, the MCOs have been pushing back and requiring rendering providers on claims, even though the state has not. So that is problematic for billing.
And that's part of what we want to work on. And I'll get back to the CCBHC thing in a second. Jay?
The other issue that would come up is currently the SUD services are factored into the case rates that each of the centers have. SUD was fee for service for years within those MCO contracts, but it's now been rolled in. So that would require a complete revisiting of the case rates.
That is true. So that decision to include the SUD services in your per member per month rates in that directed payment piece that we've added for 9/1/24, that was one of the concerns. And so what the Deputy Director, David Chorney, and our actuaries have recommended is that if centers weren't providing SUD services prior to 9/1/24 and you want to start providing SUD services, that those should be billed FFS, fee for service. They should be paid fee for service by the end, bill MCOs fee for service at those, basically. So I am going to ask them to put something in writing on that front, because you're right, Jay, that experience isn't in the current rate. So you would need to get paid for it under fee for service, right?
But for those of us who are doing it, it is in the rate.
It is in the rate, yes. So he pulled all of the utilization experience. I would keep an eye on those things to make sure it looks like it's lining up right in terms of your rate and what your utilization is telling you. Because if you folks were not certifying those individuals in your monthly data share with the MCOs for that per member per month payment in the past, there is the possibility that some of those services weren't captured. What they did is what the actuaries did is they pulled the claims using your NPIs, right? And the eligibility stuff. But there's not an identifier for eligibility for SUD only. There's just the identifiers associated with the CMH population. And when I'm saying the identifiers, I mean through the modifiers, right? So I feel like there's some margin of error potentially in there somewhere. But the CEO certainly know we worked quite closely with the New Hampshire Community Behavioral Health Association team, with Roland, and several meetings with you folks. I would just keep an eye on that in the future, and certainly make sure if you're opening up SUD only services that you have those conversations.
Thanks.
All right, we're at 10 o'clock. So that's all I have for today. In the next couple weeks, you guys should be getting a lot of stuff in writing from us, if all goes well. So thank you so much. Nice seeing all of you today. Have a good weekend.
Thank you.
Bye.
Thank
Thanks.
you.
Bye.